Good afternoon, everyone. I'm Vincent Bond. I'm Chair of the Department of Microbiology, Biochemistry, Immunology here at Morehouse School of Medicine, also Interim Director of the Natural Products Research Center, which has a interest in developing treatments and around natural products, which of course includes cannabis. I am also the moderator for this first panel. It's entitled Research, Medical Cannabis in Vulnerable Communities. And I thank the president and Mr. Dawes, who did a great introduction. And this panel, we're looking at the overall vulnerable communities and also research going on around cannabis in those communities, indicating that there are issues, but there are also opportunities. Our first panelist today is Dr. Ziva Cooper, PhD, Research Director of the Cannabis Research Initiative at the University of California at Los Angeles. And this is in the Jane and Terry Semel Institute for Neuroscience and Human Behavior. Dr. Cooper is also Associate Professor in the Department of Psychiatry. Her research involves understanding variables that influence both the therapeutic potential and adverse effects of cannabis and cannabinoids. Among her many accomplishments, she has served on the National Academies of Science Committee on Health Effects of Cannabis that recently published a comprehensive report of the health effects of cannabis and cannabinoids. And with that, I'm going to turn this over to Dr. Cooper, and welcome to Morehouse School of Medicine.
Thank you so much. It's an honor to be here today to talk about both what's going on in the country with respect to cannabis use, medical cannabis use in older adults and in vulnerable communities, and to talk about what we're doing at the Cannabis Research Initiative to help fill some really significant gaps in knowledge. So just a couple disclosures. My funding is through the NIH and through some California state grant programs. Independent of these, I've been a scientific advisor for a company called FSD Pharma located in Canada. So first, I'll provide a legal landscape of what's going on in the United States, and it's super complex with respect to the medical use of cannabis. And then I'll talk about the medical uses of cannabis and the evidence that we have for these medical uses. And I'll talk about changes in cannabis use in vulnerable communities. And then I'll talk about the path forward. So where do we see the research going to help fill these significant gaps in knowledge? So the United States is quickly going green. We have 15 states plus Washington, D.C. that have legalized cannabis for adult use, which is frequently termed recreational use. 35 states plus D.C. have legalized cannabis for medical purposes. And at the federal level, plant-derived cannabidiol, CBD, which you see all over the place, is legal at this point in time. And there are actually 700 hypothesized indications for which people think that cannabis and those chemicals in this cannabis plant might be useful for. And so here are just 68 of those 700 indications. And you can see that they range in a wide array of different types of disorders, from psychiatric to inflammatory to indications that are specific for women or for older adults. How are people using cannabis? So with the increased legalization, we're seeing all types of trends emerge. So of course, people still inhale cannabis. They smoke it using joints or blunts. People are now vaporizing it using different apparatuses, using a vape pen or a vaporizer. And both of these things can take the whole plant and heat it up to a degree where you're not combusting it. So you're just vaporizing or aerosolizing the chemicals in the cannabis plant, and it's thought to be safer with respect to respiratory function. Of course, there's been a boom in oral cannabis products as well as topical cannabis products. CBD is quickly becoming a darling of the cannabis industry. In fact, I was at the airport in Atlanta right before COVID hit, and I noticed that CBD was in all of the terminals in different forms. So you can get CBD infused athletic wear to help with muscle soreness, CBD infused pillowcases that are sold at overstock.com, CBD-infused food, capsules, and tinctures. And it's interesting because we're seeing all these changes evolve, but every state has different laws related to how medical cannabis can be used. For instance, in Oklahoma, there's not a standard list of indications for which a medical practitioner can recommend cannabis. It's really up to the judgment of the medical practitioner. Whereas in Mississippi, there are 22 indications. So there's more guidance for the practitioner. But that 23rd indication, which allows the practitioner more leeway to really judge the situation by itself. And this is confusing because every state is different. And usually physicians and patients look towards these changes in public policy as a signal as to what is the science telling us. Is the science telling us that cannabis is helpful for these 22 indications? What is informing this public policy? So we actually did a systematic review of the literature a couple of years ago, looking at the evidence supporting the use of cannabis and those chemicals in the cannabis plant called cannabinoids for the 20 most qualifying conditions across the United States. And what we found was that there was substantial evidence supporting the utility of cannabis and cannabinoids for at least 3 of these indications: chemotherapy-associated nausea, vomiting, appetite suppression, seizure disorders, and HIV-associated anorexia and cachexia. We also found that there was strong evidence supporting the use of cannabis and cannabinoids for chronic pain. Now, where did this evidence come from? The evidence came from largely studies that had been done with these cannabinoid products that are actually FDA approved. So they did not come, the evidence did not necessarily come from studies done with the cannabis plant. And so we have 3 products that are FDA approved for use that are considered cannabinoids. 2 are synthetic: dronabinol, which is synthetic THC, nabilone, which is also synthetic and it's like THC, and then Epidiolex, which is the only FDA approved cannabinoid that comes from the plant, and this is CBD. So because we just don't understand the therapeutic effects of cannabis, because they just haven't really been studied to a large degree, we are in desperate need of understanding the safety of the products that people are using, the safety of the products that are available in dispensaries, and the efficacy. So are these products able to treat those 700 indications that people think it might be useful for? We also don't have a good feeling for the quality assurance of the products that people are taking across the United States. So next, I'll talk about changes in cannabis use in vulnerable communities. First, this is a research area that I'm very much interested in, is use among women. Historically, males outweighed females with respect to cannabis use 2 to 1. But what we're starting to see is that this gender gap is narrowing. And what we've seen over the last 4 years, that as expected, women between 18 to 25 have increased their cannabis use, both monthly use and daily use. But interestingly, and this is a population that we don't usually attend to because they're not those late adolescents, women over the age of 26 have had significant increases in monthly and daily use, nearly a 50% increase. And in pregnant women, we are seeing this effect as well, where over the 10-year period that the study focused on, 2009 to 2017, there was a dramatic increase of use in cannabis, from any cannabis use to daily cannabis use. Now, what's nice, there is some reassuring data demonstrating that when you look at monthly use after 2017, what they're starting to see is a decline in monthly use. So that's reassuring because we don't understand the impact of cannabis on the fetus when it's used by the mother. So it's important that this use be curtailed because we don't yet understand the effects. In animal studies, the effects are not positive, they're generally negative. So this decline is nice to see, and it'll be interesting to see how this carries out over the next several years. How about use among Black adults? So what we're seeing here is that in that age group, 18 to 25-year-olds, we're not seeing real changes in daily cannabis use. And that's good too, because it's really the daily cannabis use I think we're most concerned about, because that usually leads to problems down the road. We are starting to see increases in past month use. But now again, if you look at the older group, the older population, what we're starting to see in Black adults 26 and older is that there has been a significant increase in both monthly and daily use. So similarly to what we see in women, across the board, we're starting to see increases in the 26 and older adults. Use among LGB adults, we're starting to see a similar trend as well, where among emerging adults, 18 to 25-year-olds, we're not really seeing changes in monthly and daily use, but we are starting to see changes in monthly and daily use in adults who are 26 and older. And lastly, one of the other reasons why we're convened here today is use among older adults. And this has really turned a lot of attention to research in this population, because there has been an over 400% increase in use in this population, both in adults who are 55 to 64, as well as 65 and older. And we have very little data understanding the impact of cannabis use in this population. So we have a rapid growth in industry, lots of different products that people are using, novel products, new ways to use them, and people are using these products for a wide range of medical indications. We know that there is therapeutic benefit of the chemicals in the cannabis plant, and this has been shown with the FDA-approved medications. But we have a long way to go, because as you saw, we only have about 4 indications for which we have really good, solid data supporting the use of cannabis and cannabinoids. We also know that there are adverse effects, which I haven't really touched on great length here, but hopefully some of the future speakers will touch on these adverse effects, because they're really important to keep in mind when we're thinking about the clinical utility of cannabis as a therapeutic. We have a lot of unknowns with respect to the products that people are using. Are these products safe? Are they safe at certain doses? Are they safe over long periods of time, the way that many people are using these products? And we also have very little knowledge about the impact of these products in vulnerable populations and people 65 and older. So how are we filling the gaps in knowledge? So at UCLA, we have the Cannabis Research Initiative, which was founded in 2017 with the help of Dr. Fong, who you'll hear from next. And the goal of the UCLA Cannabis Research Initiative is to understand consequences of cannabis and cannabinoid use. Very broad topic. We're interested in looking both at the potential therapeutic effects of this plant and these chemicals, as well as the adverse effects, so that we can be better prepared to understand how these drugs can be used in a therapeutic setting and how use can become hazardous, or what type of use is actually hazardous to health. And the next goal is to help to educate the public. There's very little knowledge in the general population, and as well as in medical institutions, about cannabis, cannabinoids, and the endocannabinoid system. So within the UCLA Cannabis Research Initiative, we have a research laboratory where we actually do double-blind placebo-controlled studies where we're trying to understand how these chemical constituents might be therapeutic. So some studies that we have underway addressing vulnerable communities and underrepresented communities is understanding directly how males and females differ in their response to cannabis. So we have a study where we're actually giving cannabis to males and females, and we're looking at both adverse effects as well as pain relieving effects. We're also very interested in understanding the impact of cannabis use in the aging population. Right now, we don't have a study underway, but this is on our radar to be able to pursue this in the coming years. Next, we have a postdoc who actually has a couple of grants funded in this area. Her first grant is looking at cannabis use in African-American pain patients and trying to understand the impact of their cannabis use on their pain as well as their cognition. And she also has a grant looking at racial, gender, and socioeconomic landscape of the California cannabis industry policies. So we're really excited that those projects are underway, and they'll be able to really address some of the questions that I think we'll hear a lot about during the course of this event. And with that, I'll conclude. Feel free to check out our website or follow us on Twitter if you're interested in hearing the latest in cannabis research and what we're up to. Thank you so much.
Thank you, Dr. Cooper. And we're going to move next to Dr. Fong. Our second panelist is Dr. Timothy Fong, MD. He's a clinical professor in the Cannabis Research Initiative, again in the University of California, Los Angeles. And he's professor of psychiatry at the Semel Institute for Neuroscience and Human Behavior at UCLA. He's board certified in adult and addiction psychiatry. He's the director of the UCLA Addiction Psychiatry Fellowship, a one-year program that provides clinical training in the management of addictive behaviors. And he's also the co-director of the UCLA Gambling Studies Program. So with that, I'm going to turn it over to Dr. Fong, and welcome to Morehouse School of Medicine.
Good morning, and thank you for having me out here on such a beautiful day here in Los Angeles. I want to thank Dr. Standifer for inviting Dr. Cooper and myself to participate. I met Dr. Standifer back in LA probably way before COVID started, and this really started this conversation. As you can see, my background here, this is our UCLA Cannabis Research Initiative, and I really wanted to bring to you today kind of my perspective on what I've learned doing cannabis work over the last 4 to 5 years, predominantly as a physician and as a psychiatrist. So the first thing I want to emphasize is this, is that there's such a huge amount of work to be done. But for me, as a physician, there's so much more work we have to do for medical education, and that's absolutely the most important thing. Our UCLA medical students can go through 4 years of UCLA medical school here and get very little in training on medical cannabis, and we have to change that. Let me start off with a case, and this is a case that is active in my outpatient practice. He's a 65-year-old man with chronic low back pain, depression, and a combination of alcohol and opioid use disorder. Over the last year, he contracted COVID, he lost his job, he can no longer afford his medications for depression and opioids for his back pain. He turns to cannabis as a cheaper option, more affordable, more accessible, more available, seemingly, quote, more equitable. He uses flower, he uses edible for about 6 weeks. But he says it's not as good as the opiates for his pain. He says his thinking is a little more clouded. He says he can't sleep as well. And then seemingly out of the blue, he attempts suicide by taking a kitchen knife and jabbing it into his neck 7 times, resulting in a psychiatric hospitalization where I met him. The first question I asked is, what role did cannabis have? The medical students and residents turned to me to say, what are you talking about? There's no way cannabis could have impacted his mental health. I said, why not? Because the residents and medical students said, because it's just weed. They said there's no way cannabis actually triggered and worsened and caused him suicidal ideation. My question to this panel, to this roundtable is, really? And if that's true, what can be done? What should be done? I can fast forward to the case 2.5 weeks later. He cleared up, went through cannabis withdrawal, the depression improved, and it was very clear that his cannabis use was about 70% of the story that led to the suicide attempt. So one of the first things I say to a lot of our medical students is this. I'll say that cannabis is a substance that changes how our body, brain, and mind functions. But a medication restores normal functioning of the body and the brain and the mind. So how do we ensure that cannabis goes from being just a substance to actually being a medication? And that's our goal here today, tomorrow, and all the work moving forward. As Dr. Cooper mentioned, this is a national survey on drug use and health for 65 and older. I should qualify that here at UCLA, they consider a geriatric population as 55 and older. So I find myself nearing that very close. So 65 and older. And again, imagine 12 years ago, 0.4% of the geriatric population using cannabis, 4.2% in 2018. What will that number be in 2030? We're staring at the precipice of not an epidemic, but of a rise, a tsunami of cannabis use to be used by older adults, and we have to do better. Why do people use medical cannabis? This is data now 10 years old. Just asking people as they come out of a cannabis dispensary, why are you going in there? Why are you buying cannabis? And isn't it amazing? You look at that column: pain, insomnia, anxiety, muscle aches, nervousness, can't eat, nauseous, emotional pain. The things that are so prevalent and so under-recognized, under-treated in the 65 and older community, as well as vulnerable populations. This is why cannabis has taken off. This is why cannabis demand is through the roof and is not going to go down. So I think here are the critical issues of the 65 and older and the vulnerable communities. Number one, we must prevent harm. We must prevent harm. As an addiction psychiatrist, that of course is the lane of addiction, cannabis use disorder. I'm very concerned about that. When I tell medical students, when I tell people who say, you can't be addicted to cannabis, I said, false. We know that it carries with it about a 9% chance of developing addiction from the very first time you ingest. The very first time I take broccoli, or the very first time I take kale, that's not a 9% chance, and that's a significant risk. Number two, the toxicities of the cannabis products that are available on the markets, where I can walk down to my office here in UCLA and walk into Westwood, and within the next 10 minutes, I could have in my hand a high potency cannabis product, well over 60, 70% THC. So you hear about those questions. Number one, the toxicity that comes from the state of intoxication. You'll hear through the years, no one dies from cannabis overdose, but people do in fact die when they're intoxicated by cannabis, car accidents, injuries, traumas, falling off buildings, things like that. Adverse effects, again, side effects from the toxicity from taking cannabis, again, whether it be sedation, motor incoordination, mental health adverse effects. For the 65 and older, the drug-drug interactions. Average number of medications that our population at UCLA when they come into the hospital, they're on at least 8 to 10 medications. We know that cannabis has drug interactions. It can elevate those prescription medications. It can reduce the metabolism. And what about those impacts of those prescription medications on cannabis in of itself, changing drug levels? And lastly, the real question about, will cannabis exacerbate medical and psychiatric conditions? Would it actually make your depression worse, not better? Could it actually make your pain better or not worse? What about insomnia? Again, many, many questions, all folded to that single question of all the work we have to do is geared toward preventing harm. The second part of this is cannabis research and education to promote health and wellness. And I saw this last week on a show, and it really stuck with me, this idea in medical education. We always talk about everything that goes wrong with the body. We talk about everything that could go bad. Well, why aren't we talking about things that would make it better? Why aren't I reimbursed more money for getting people to lose weight, stop smoking, stop using an addiction? Why am I only getting paid to keep people coming back and getting more prescriptions? So I think there's something different there. We have to reverse course to promote cannabis as a healthy recreational aspect when it can be, and cannabis as medicine. And I'm using the question mark, is it really? Or the exclamation part, it really is. And that's part of the story of how we want to promote health and wellness. Okay, so here's what I've learned since 2016 when we embarked on cannabis work. There's so much more that we don't know than what we know. Well, that's very profound, but essentially it's that. The therapeutic potential of cannabis as a medication versus the established effectiveness. That's where we need to change the language so we have some more therapeutic established effectiveness. And we're nowhere near that, but we're on that way. Number two, from a psychiatrist standpoint, we miss so many times when cannabis goes poorly, when there's cannabis withdrawal, cannabis-induced disorders like depression, psychosis, anxiety disorders, or just frankly addiction. So many times I've seen emergency rooms miss it, primary care doctors miss it, therapists miss it, and most importantly, families members miss it. I had a patient yesterday, he said, I've been using about 2 grams of cannabis for the last 10 years. Not a single person in my life has actually said, I'm worried about your cannabis use. And when I went through the cannabis use disorder criteria, 10 out of 10. Severe cannabis use disorder, easily miss. So we have to do better with that. My current view on cannabis and its use as medication for mental health. So this is really cannabis to treat depression, cannabis to treat PTSD, cannabis to treat anxiety, is that unfortunately, as of today, it's just not there. It is probably more likely to be harmful to your mental health if you're trying to take cannabis to treat your mental health than it is to be therapeutic. Again, very different than physical, but that's my current view on that. And that's reflected in a number of our position statements from cannabis and mental health. I'm an executive board member. I'm a secretary of the American Academy of Addiction Psychiatry, where we put out position statements on this. Here's a roadmap of the various types of cannabis-related disorder conditions we're concerned about. And point number 1 is that it can be addictive for upwards of 9 to 17% of those who use, and up to 50% of people who use on a daily basis. That's number 1. Number 2, this criteria for cannabis use disorder is very confusing. And again, it highlights that when patients present with this signs and symptoms of addiction, it looks different. 10 patients, 10 different stories, 10 different outcomes. So that's why cannabis and preventing this addiction is so important. If I said to you that we raise the prevalence of cannabis use disorder by just 1% in this country over the next 5 years, we're talking about millions of Americans now with a new disorder. Number 2, unfortunately, it is now scientifically true that it can cause transient psychosis if you're intoxicated from just a single episode of use. And that risk is high with edibles and high potency products. Last week, we had a gentleman who drove out to Arizona, to Sedona. He took 3 edibles. He became so psychotic that he had to be psychiatrically hospitalized. 3 edibles. To the point where he was hallucinating. He thought police were after him. He thought the Martians were coming, and he was just so disorganized. 3 edibles. Point number 3, we know that if you have existing psychiatric symptoms, depression, anxiety, PTSD, eating disorders, psychotic illnesses, the cannabis will more than likely worsen that condition than it is to actually help it. Point number 4, there's no currently, as of February 2021, insufficient evidence for, again, the treatment of using cannabis as medical cannabis to treat any psychiatric disorder. I hope we can change this slide in the next 5 or 10 years. I wish I could say with confidence, yes, that this version of cannabis is very good for depression, or this version and this route of administration and this particular dose is great for sleep. We can't say that. We have a lot of anecdotal stories. We have a lot of people saying, yes, cannabis did this for my mental health, but it's not yet backed up by the high quality science and the clinical trials. American Psychiatric Association has put out this position statement in opposition to cannabis as medicine. Now, I always think about this, what does this do? So when you have physicians saying very strongly in 2019, no scientific evidence that this is for treatment, further research is necessary, lots of variability, lots of availability, we're not sure what this is actually going to do, but the position stalls. I'd like to see it to the next level. What is the APA actually going to do beyond this? We can put out position statements, but I'd rather put out position solutions. Let's put out a roadmap to actually tackle some of these statements instead of just putting words like oppose, block, things like that. And that's really where I have this roadmap. Or the first I want to bring up is what will happen in a decade, 20 or 30 years. I think about our 15-year-old son. I talk to him about cannabis every single day. I say to him, when you're 25 and when you're 35 and when you're 45, are we going to look back and say, do you remember 2021 when we really pushed out cannabis and we didn't do it properly and now we have a cannabis crisis on our hands? If you said that to me in 2002 about opiates, I would have been like, what are you talking about? There's not going to be any crisis. Obviously, there is 20 years of opioid crisis. So to avoid that cannabis crisis, and how do we do that? That means we have to study it from a public health impact. Look at the car accidents. look at the environmental impact, look at the financial impact, look at its equity. And to look at, again, minimizing the impact of cannabis addiction. How do we prevent cannabis use disorder? We have to go back and teach people that this is a potentially addictive substance. We have to implement the tools of prevention for addiction earlier on so that people don't fall into that. And lastly, the biggest area is medical impact. We have to not only have research to guide clinical practices, but we need to start with proper education in all the healthcare fields, starting with day one. We did a couple of surveys of medical students and their first year medical students, and they came in with preconceived notions of what cannabis is and is not. We can't do that. Right now, it is not mandatory in medical education to put in X number of hours on cannabis education. It just doesn't make sense. And so what happens then is our medical students do the same thing as anyone else in the general public. They just listen to the hype, or they listen to podcasts, or they hear about it from a friend. They don't learn from the scientific truths that we need. So my part of the roadmap, I think moving forward, we have to, number one, learn from the lessons of tobacco and alcohol to avoid the predatory practices of those industries on older populations and vulnerable communities. We have to do that. And number two, we have to really focus on credible sources of information. If I said to everyone in this room right now, give me 3 places where you get information on cannabis, Wikipedia is still going to hold out there. Leafly, High Times, various podcasts are still going to be out there. We can't do that. We have to go back to sources of information that are vetted, that are peer reviewed, and that stand the test of time and credibility. Reward health and wellness. I can't say that enough. Reward health and wellness. Don't punish. Don't stigmatize. Use the term science-based legislation. Our advocacy efforts have to do that. We have to emphasize if you're going to do expand cannabis or restrict it or promote it, we have to use science-based. An example, should there even be high potency products 60, 70% available on the market, in the free market? I can't answer that question. But when I think about tobacco and alcohol, we have upper limits of potencies that we allow, that we regulate, that can be sold on shelves. And yet we don't have that when it comes to cannabis. All right, Dr. Cooper mentioned our website. Please take a look at our website, cannabis.seminole.ucla.edu. We have videos, we have lots of great information. And again, please follow our Twitter handle. This is brand new for us. We only have like a couple hundred, maybe less than 150 followers. We want to get bigger. We want to be absolutely the biggest number of followers, disseminating information about cannabis. We're going to put up articles, we're going to respond, we're going to put up responses. Hopefully we'll be able to put up reports from this conference onto that Twitter. That's our staff. And with that, those close my formal comments. Thank you so much for your attention. And I really look forward to continuing to participate over the next day and a half here.
Thank you, Dr. Fong, for that overview and laying out the issues and potential solutions. Our third panelist is Dr. Juanice D. Taylor, PhD. She's Chief Diversity and Inclusion Officer at the University of Mississippi Medical Center and Associate Professor in the Doctor of Health Administration program in the School of Health-Related Professions. Her areas of interest include diversity, inclusion, health equity, and access to education. Prior to UMMC, she led federally funded programs to increase diversity in STEM and biomedical fields at the University of Mississippi and Auburn University. And I just want to note that the University of Mississippi hosts the NIDA-funded contract to provide pharmaceutical-grade marijuana and marijuana-derived project materials to NIDA's drug supply program. So with that, I would ask Dr. Taylor to go ahead and present. Thank you.
Thank you so much for that warm introduction. It's a pleasure to be on this panel today. So I come to speak to you on behalf of the diversity, equity, health equity, and inclusion practitioner standpoint. So I'm going to start my presentation really focusing on the cycle around stigma and bias and how that plays into this work. So let's talk a little bit about the cycle of poverty and disease. We know that poverty is both the cause and a consequence of poor health. This current pandemic that we're living in is the latest awareness or awakening of how being poor affects our health or your health, and with low income communities being affected greatly. And this ugly revering or reminder that poverty itself is a disease. But also within this cycle and beyond the current pandemic, we see what we know as endemics: social stigma, poor housing, loss of healthy life, infection, reinfection, malnourishment, the lack of educational opportunities for our children, poor cognitive health and growth and development, unrealized potential, chronic illnesses, and comorbidities. So just to level the playing field a little bit, who's among the most vulnerable? So what we've heard so far is the chronically ill and the disabled, low income and homeless individuals. There are certain geographical communities, our LGBTQ populations, the very young and the very old. So much of the stigma around the use of marijuana is due to early laws and criminalization, which really commenced to the war on drugs. We know that while medical marijuana is becoming more prevalent in society and more acceptable, it's still not supported at the federal level. These misconceptions and negative ideologies about marijuana is permeated deeply in our visual portrayals, which perpetuate these different stereotypes associated most often with crime, drug dealing, and even these sexually promiscuous advertisements or in films, which continue to fuel the stigma around marijuana. Sadly, as more white people in the 60s, white middle and upper class Americans were using drugs recreationally in the 60s, it would be Blacks that would be criminalized for it. And lastly, even if medical marijuana is legal on a state level, the broad language of the law, which permits physicians to recommend marijuana when it is determined that a patient's health would benefit, has led to some abuse. And even though it's meant to sound or benefit the seriously ill, it's often not acceptable to do so. So as my presenters, talked about, what we know is that there's been a significant increase among the 65 plus population in terms of who's using marijuana. But we also know, and it was stated earlier, that 93% of women 65 and older between this 4-year period, and nearly 114% of those women had a college education. We also know from the research that married adults and those with higher incomes also experienced spikes in cannabis use, as did racial and ethnic minorities. So let's talk a minute about, these religious ideologies in the South and why it's taken us so long. We know that religion is really an important part of the traditional landscape here in the South, especially in a state like Mississippi. And our culture is typically shaped by these ideologies. However, both economically and racially, we still have a long way to go. The innermost part of this graph here that you see on the left in the dark green really represents what we know as the Bible Belt. And because of the prevalence of Christianity in the state, about 34% of the 76% of the Christian faith are described as Protestants, whereas another 15 or so percent describe themselves as Catholics. And then there's another 19% that describe themselves as agnostic or atheists. The map on the left also shows that the darker states claim to be the more the more religious states. However, in thinking about the data, just listen to this. The Bible Belt, as I just described, have the highest number of tobacco users, have the highest rates of infections, specifically STDs, and have the highest teen birth rates. So here we are, battling. Do the southern states really truly practice what they preach? And the map on the right really demonstrates the growing number of states based on the most recent election approving the recreational and medical use of medical cannabis products. So what happened? Oh, let me back up. Sorry about that. So what happened in Mississippi in November? This historic and overall vote in Mississippi's 2020 election sent shockwaves through the minds of many here. Not only was a new state flag approved, so was the legalization of medical marijuana. Politicians didn't want any parts of it. The medical community didn't want any parts of it. Law enforcement didn't want any parts of it. Politicians continuously talked against it on conservative talk radio, criticizing it. So why did it pass with over 70% of voters? I don't have the answer to that. But if I was to guess, perhaps people became more aware of its use. Maybe they've been using it anyway. However, maybe voters just recognize that it's not a political issue anymore, yet one that's based on a moral case, that those living with these diseases and these conditions, or in a state with the worst health outcomes, needed this to survive. Yet even with the vote in Mississippi, there are still opponents for this law. Currently going into deliberations with the Mississippi Supreme Court. Even national associations and regional and statewide associations are really asking the courts to overturn the will of the voters, which approved this reform in Mississippi. So time will only tell what's next for the state. Sorry, I'm moving too fast. So I can't help but to address provider bias, because this is something that my team talks about all the time when we're trying to educate our providers and our students here at our medical center. Again, the medical community has been historically dismissive, not so much even as it relates to this topic, but patients of color. Again, what we know about this, there are significant knowledge gaps. We're still unsure about the risk and the benefits of medical marijuana usage. So again, there are strong proponents against this passage of this new reform. The lack of communication between doctors and patients. No matter how much community education that we bring or awareness we bring to these topics, if doctors are still biased against their patients due to stereotypes and bias, and patients don't trust their physicians, and there's this strong level of mistrust, patients will continue to go elsewhere to use this, and they won't ever tell their doctors that they're using it because of the stigmas associated, the stigma and the stereotypes and the biases associated with the use of medical cannabis. So just to give you just a few data points on recent studies, from the patient perspective, Black, Indigenous, people of color continuously report poor quality of care linked to their race and ethnicity. There's also several reports that white patients receive better care than 41, and in thinking about this, 41% of Blacks, 37% of Hispanics, and 32% of Indigenous populations, including 20% of Asians feel this way. Non-white, low income, and uninsured patients are less likely to report being treated with respect. Non-white, low-income, and uninsured patients are more likely to view healthcare professionals' cultural competence as important. So what can we do about this? As I leave you and as we begin this discussion, perhaps there are a few inclusive healthcare practices that would be ideal for thinking about how do we advance this conversation and this work. But first and foremost, we need more people to be more open-minded. Patients have the right to be treated with respect, whether it's for or against the use of medical cannabis. Healthcare professionals must not be non-judgmental to build this patient trust. And then cultural competence. even beyond cultural competence, there's structural competence. And so we need to really be thinking about not only the provider's cultural competence, where they should be culturally sensitive and familiar with the patient's cultural beliefs and access to care to diminish the impact of bias, but what structures or systemic things are in place that's hindering the access to the use of this. And then continuing education. Providers must continue learning about the use of medical cannabis and partner with institutes and research centers that are doing the work. There's no gold standard of its benefits or risks. We already determined that, but the greater risk is that the patients will seek out other, less reliable sources while continuing to use it. And of course, equity. These unintended consequences of legalizing medical cannabis is inequities, so social and economic. And we need to think about how legalization must consider the impact of these laws and the enforcements as such, so that we won't continue to perpetuate stereotyping and biases and profiling of those users. And then lastly, healthcare workforce diversity. I cannot speak enough about how important this is, and it's the responsibility of medical schools to continue to improve the pipeline and pathways to create a more diverse workforce and increase efforts to eliminate persistent structural racism that exists in the healthcare delivery system. So I'm going to stop there. I look forward to the conversation so much, and thank you for having me.
Thank you, Dr. Taylor, for your presentation on vulnerable communities and inclusion of those communities. So at this point, I think we're moving into the Q&A session. And I just must say, listening to the presentations, it's overwhelming, as Dr. Wong said, how much we do not know, but how much there is to do, given that basically we have a system that we've just recently identified in the human body, and we have molecules that we know can modulate that, but we know very little about either of those systems. So I guess I tried to break this down somehow to come up with some questions, and I was looking to break this down. I can see political issues, medical issues, research issues, but when I started thinking that way, overarching question is that when you look at how we usually attack problems like this, these large problems, we attack these medical problems nationally through NIH, et cetera, and using science-driven solutions. And I've heard using community input through education and community input into these issues. So I guess my question to the panel, the three panelists, is where did we go wrong, and how do we begin to address this to get the government nationally, locally, statewide to look at this as a problem that needs a medical and science-driven solution with lots of community input? I guess that would be my overarching question. That seems to me to be the first point, because we're already on the bike. And so now we've got to do something quickly to make sure we don't get any worse and go down the same road, opioid road or whatever.
So I'm the non-physician, on this panel, and the first thing that comes to mind is clinical trials. One of the first things I thought about when I was invited to do this talk is I really wanted to see how many clinical trials involve medical cannabis. And when I asked this question to our Office of Clinical Trials, there's one around pediatric, I think, epilepsy. And so, however, the comment was, we hope to have, there's been discussion, we hope to have more in the future. So we already know the lack of diversity in clinical trials, with what, 13% of the United States, African American or people of color, and less than what, 3% involved in these clinical trials, and 1% for Hispanics. Until we get some of that trust correct, and the level of engagement where we're going in the communities, we can't just go in the communities. We have to come back to the communities as well. So we can't go and ask and vet our research study participants. We have to talk about the successes and what our findings are, and continuously engage in these communities. And so that's something that I try to promote with our research teams, in a coordinated course that they take. But this, to me, again, is of the utmost importance. Until we get more diversity within our clinical trials and in our studies and involved in the conversations, I think that's a starting point.
Yeah, and so I like to jump in here. And Dr. Bond, you said, what did we do wrong? At what point did this explode, or did this end up veering in the wrong direction? And I think, looking back at history, in the 1930s with the Marijuana Tax Act, where essentially beforehand cannabis was on the pharmacopoeia and it was being used, regardless of the fact that there wasn't really the double-blind placebo-controlled studies that we have, or we hope to have now. And I think because it then became illegal on a federal level, it led to the stigma, and it led to underground use, and it led to, I think, what we have now, where there's now a lifting of the stigma and this permission to, I think, explore the commercial aspect to it. And there's one end of the spectrum, which is exploring this from an adult use and recreational market, where we're seeing these hazardous products, potentially hazardous products, being put on the market, these extracts that are almost 100% THC, and then a burgeoning, growing medical community, medical market, where the people who are looking for alternatives to their prescription medications that aren't helping, or they have various side effects, they're hearing from the industry or from media about how CBD with a little bit of THC might be very helpful. But in general, the population doesn't understand that we don't have the scientific evidence and what the main risks are at this point. One of the main risks is that this is unregulated. Some states have very good regulation with quality assurance of their products, but a lot of states at this point do not have that infrastructure. And I think the first aspect of this is really educating people to understand that you may have heard that CBD is amazing for your pain, that it's better than opioids. But guess what? There hasn't been a single double-blind placebo-controlled study of CBD for pain yet. People are disconnected from what the evidence is, and they're also disconnected from what the risks are, as Dr. Fong pointed out. And so I think that education is really a ground level way to start doing this, because unfortunately, as a scientist in this field, the industry and public policy is running away from us. We cannot possibly catch up at this time, even though there's an explosion of studies that are happening related to CBD for this indication, that indication, cannabis for this indication, that indication. There's no way that we can possibly keep up with the market. I wish we could, but these studies take a long time. They require a lot of funding and a lot of stamina. And I think that while we're trying to provide answers to help guide public policy, the public policy changes have happened, and they're going to continue to happen. And so we really have to address this at a community level, I believe.
Just so much. And let me just start with echoing that, but I'll start from the top down. There's no national response. I mean, it's just like COVID. I mean, it's nothing. So of all the NIH funded stuff, there's no NIH Center on Cannabis Studies. It's all going to be inside NIDA or NIMH or NIAAA. So we don't have that. We don't have a really terrific national task force on this. I don't think we ever will. I mean, it's with the new administration, there's lots of great hope there, but I think that's number one. Number two, I think about CPR. CPR is a great example where, how do we know what works for CPR? How did CPR even get started? It started by a bunch of healthcare professionals getting together and saying what works, what doesn't work, and creating, American Heart Association and standard guidelines from professionals. For me as a physician, that's where we've done very, very poorly for physicians inside professional societies, whether it's the AMA, the APA, or anything like that. There's one professional society for cannabis, Society for Cannabis Clinicians. It's very small. It's not really recognized as a, quote, professional society. It's seen as a bunch of docs who love cannabis, and that's not true. So until we have professional societies actually having standing committees, standing people who are working together with the people in Washington to influence things, we're going to have a lot of this scattershot area. The other part is that partnership between nonprofits, for-profit cannabis industry, and academia is very, very critical. When we built Cannabis Research Initiative here at UCLA, I thought wrongfully the first year, I'll just go out, get like a bunch of funding from cannabis companies, and we'll have literally $20 million in a year. I was not prepared for the sheer backfire and backwash against, you cannot work with cannabis companies. And I would say, why? Federal law, state rules, all these various things. So until we have those really good partnerships with cannabis industry, nonprofit, community organizers, and academia that really will have those products, we're going to have everyone doing their own agenda. I remember, and you're coming to us from Atlanta today, I remember doing an obesity conference about 15 years ago there at headquarters of Coca-Cola. And it was fascinating to me today what they did there. They had Coca-Cola, private industry, bring the top obesity researchers in the world all into a one little 2-day conference. The amount of learning and education and inspiration I got from that just 2 days was enormous. Those are the things that aren't happening at a general level. So what we're doing here today is absolutely the start. It has to be the groundswell into a lot more community organizations and products. The biggest thing, again, is when I can't say it enough, when we Google cannabis as medicine, we don't get credible source of information. I think a product out of this group would be a credible source of information. It's just how do you get the attention of the world? So lots of other things to comment, but those are some main points right there.
Great. I've just been told we have 1 minute to close out our discussion. So again, I would.
We have 2 questions from our community invitees in the chat, actually 3 now.
Okay, quickly. I noticed we have one community organizer that asked how they can get involved. And I think, Dr. Fong, you kind of addressed that, but does somebody want to quickly address that? How can I get involved? Not even to find out how to grow this product, right? They want to know how they get involved with the entire CBD issue. Because it sounds like you're saying community organizers from grassroots, that could be a way of addressing this problem. Would you agree with that?
Yeah, I think we all would. I mean, again, like in California, getting involved with our Bureau of Cannabis Control, getting involved in any academic committees that are open and having community partnerships. We have a whole host of nonprofits here in Los Angeles that are working toward equity and access and availability and education. And they need to be involved by getting involved with academic centers like ourselves that want to learn and partner with each other. But state of California, again, they have community membership spots available for cannabis regulation, and they by law are required to have public participation in their regulations and policies that they create.
Great, thanks a lot. So I'd like to thank the panelists for this first panel discussion. And with that, we want to close out this panel and move to the next one.